Good morning, everyone. My name is Amanda Garzon. I'm the Director of Communications and Marketing for the Hydrocephalus Association, and I want to welcome you to the NPH Outcomes and Ongoing Management After Treatment session. Before we get started, I'd like to take a moment to thank all of our sponsors for making this event possible, particularly our platinum level sponsors, Medtronic and RSRI. There will be ample time for questions and answers at the end of the sessions. To ask questions, I'm going to distribute cards unless you see them on your seats, but I will walk around with some. And I will be facing you, and so if you just raise your hand with the card, I'll come by and collect it, and I'll bring it up to our speakers so that they can answer your questions. Okay? I just asked a little bit of housekeeping. Can everybody make sure that their cell phones are turned off or to silent so that we don't have any interruptions? We are live streaming this session, so I'd like to welcome everybody around the country who is watching our session with us today and really around the world. Good morning. I just ask that we keep side conversations to a minimum, again, because it'll pick up on the audio and it'll make it hard for the viewers at home to enjoy our session with us here. So with that, I'd like to introduce our speakers. To my immediate left is Dr. Norman Relkin. He's an independent medical consultant and a retired faculty member of Weill Cornell Medical College in New York City. And then next to him is Dr. Mark Hamilton. He's a member of our HA Medical Advisory Board. He's also on the HA Board of Directors. He's from the University of Calgary in Alberta, Canada, and he is a neurosurgeon. And both of these gentlemen also serve on the Adult Hydrocephalus Clinical Research Network, which is our research network focused on improving the lives of adults who are living with adult onset hydrocephalus, congenital hydrocephalus that they've transitioned into adulthood, and normal pressure hydrocephalus. So with that, a warm round of applause for our speakers, and we'll get started.
Thank you, Amanda, and good morning to all of you and everyone out there. So we're going to talk today about the management of hydrocephalus. I thought it would be useful to give both a neurologist perspective. We typically get involved in managing hydrocephalus in coordination with a neurosurgeon, since we don't put the shunts in ourselves. But it is very important, in fact, in this disease more than most, that there be a team approach and that there be a sense of the long run, because it is a chronic illness and it requires chronic treatment. The treatment, as most of you know, is placement of a shunt, which I think by now, and most of you know, is a device for draining fluid away from the brain into another part of the body. It is not 100% clear to us yet how a shunt works, but we have a pretty good sense that it does work in the right patient when placed and managed in the right way. So let's talk about what management means in the context of adult hydrocephalus. This is a chart showing a typical process of diagnosis, assessment of surgical candidacy, placement of a shunt, and follow-up over the course of the first year of treatment. People come to the process differently, and those of you here who've already been through the evaluation and or placement of a shunt know that there's sometimes a pretty long delay between the onset of symptoms and that first visit to the doctor. Often that first visit is to a primary care physician who may or may not recognize it as something that requires neurologic or neurosurgical follow-up. And typically, because the first symptoms can be confused for other things, arthritic conditions, problems with the spine, Parkinson's disease, etc., there's often an additional delay in which these other processes are addressed, sometimes by medicine, sometimes by physical therapy, and often without very good response. Once the condition gets identified as possible hydrocephalus, the evaluation process can take between 1 day and 6 or 7 weeks or more. What does that process involve? Well, there's an in-office testing to evaluate the clinical symptoms and history associated with the condition, and an imaging study, usually an MRI, as well as laboratory tests to rule out other conditions. Once those are completed and the doctor has a sense that this might be normal pressure hydrocephalus, the next question is it a treatable case? And what does that mean? Well, surgical candidacy is assessed in a couple of different ways. One is in a general medical way. Is the individual able to tolerate general anesthesia and the stresses that surgery places on the body? That's an assessment that's usually made by the primary care physician. The other part is an assessment of what is the likelihood that this particular individual is going to benefit from the surgery. And that can be done by a number of what are called prognostic tests, the most common of which are drainage procedures like high-volume spinal taps or external lumbar drainage. Once those procedures are carried out, the doctor will have an assessment of the likelihood of response to surgery. And we weigh that against the likelihood of adverse consequences from surgery. It's the balance of risk and benefit that ultimately leads to the recommendation to go through with surgery or not. That process being completed, the next step is to involve a neurosurgeon. Neurosurgeon will do their own assessment, and sometimes they are the first line of assessment, but in my practice, I would refer to a doctor like Dr. Hamilton. He would see the patient I've evaluated, look over what I've done, and then explain to the patient in much greater detail what the risks of surgery are, what the likelihood of positive and negative consequences are, try to set up reasonable expectations about what the outcome might be. Then the surgery happens. Sometimes there's an additional delay getting OR time. So this process of getting from first symptoms to the operating room can take months to years in some cases. But we know that outcome is better the sooner the operation takes place. So now the operation takes place. In modern hands, using programmable shunts, the period of time in the hospital is relatively short in most cases, 24 to 36 hours. You come in, that day you have the shunt placed, the next day you go home. That's possible because the newer shunt technology allows us to set the opening pressure of the valve to something that's not dramatically different from what the pressure was inside the head prior to the procedure. And that means that the person can get up right after the surgery and go home soon after. In the old days when we had only fixed pressure shunts, typically the person had to lie flat for 24 hours and stayed in the hospital for 3 or 4 days. So that process has improved quite a bit, but it has its own cost, and one of the costs is literal. The programmable shunts cost more, but they also require more follow-up. So what is that follow-up process? Typically, the first follow-up visit takes place around 10 days after the operation, when the steri-strips, sutures, staples are removed from the site here, here, and here, where openings have been made into the body. The wounds are inspected to make sure everything is healing as it should. And sometimes in that first day period, a brain imaging study is performed, typically a CT scan, but increasingly with the availability of shunts that are MR resistant or MR safe, MRIs are being used more often in the post-op follow-up period as well. The next follow-up is typically within the first month, and it's at that visit in which a shunt adjustment will be performed. Now, the decision about whether or not to adjust a shunt is based upon how the person is doing at the setting they got after the operation, as well as a number of other decisions, the type of shunt they have, the pressure that they had at the time of surgery, et cetera. And what we're always looking for in making the decision about shunt adjustments is, are there any complications or setbacks? So sometimes the adjustments are made in the direction of more flow out of the brain to try to optimize the response to treatment. But sometimes a patient will come in with complaints of dizziness or headache and other problems, and that will lead us to regulate the valve pressure in an upward direction. Most of the time, and again, everyone differs in terms of how they do this, but most of the time we won't make shunt adjustments more frequently than every 2 to 4 weeks. Because there is a period of time after each shunt adjustment that the body has to really adjust to the new pressure setting. going faster than that runs the risk of over-adjustment, and I think would increase the risk of side effects. Now, most patients require 1 to 3 adjustments under current protocols. Some require none. But every patient, regardless of whether they have shunt adjustments, needs to have follow-up after a shunt is placed. Anyone who has a shunt placed has a foreign body inside of them for ostensibly the rest of their lives. And that does require careful follow-up. And in the course of this meeting, and certainly in my clinical practice, one of the causes of problems is people forget about that. Sometimes it's because their doctors haven't made it clear to them that follow-up is necessary. The minimum rate of follow-up should be once a year after shunt placement, but we typically recommend more frequent follow-up in the first year because experience has shown that when problems occur, it is most commonly in that first year. So we follow our patients after the first set of adjustments at 3, 6, and 12 months from the time of surgery. So that's a general picture of what one goes through in coming to see a doctor with suspected hydrocephalus to getting the treatment and having follow-up. But a lot has to happen within that time period. And this is, I think, a good illustration of what the road to recovery looks like when you have a shunt placed. One of the most fortunate things that can happen is sometimes right after a shunt is placed, a patient will be fortunate enough to have an immediate response. They will get off the table in the recovery room and be able to walk right away. Even in those cases, it is not unusual to see a decline 2 or 3 weeks later from an initially very good response. There is debate as to why that occurs. One theory is that at the time of operation, a lot more spinal fluid gets removed than the shunt itself takes off. So it's, in essence, doing a drainage procedure in addition to placing a shunt. And over the course of the next couple of weeks, the body may catch up and a little more fluid accumulates, and then we rely on the shunt to adjust for that over time. But those of you who've had a shunt, I see some head shaking in the room, know that it isn't necessarily the case that it only gets better once the shunt is placed. And that's an important thing to remember. People get very worried when they see this kind of decline. Now, there's another set of circumstances in which things get better and then gets worse, and that's a very, very important one to recognize, and that's when complications occur to surgery. So patients get better at different rates. We do want to see a general upward improvement over time. We see differences at the rates at which gait disturbances, urinary symptoms, and thinking abilities recover. All of that is expected. What we don't expect to see is a dramatic downturn at any point in this process. That is the alarm bell. That says it's time to get back to the doctor as soon as possible. Those are the bumps on the road, and the bumps on the road may be due to just how the body is responding to the treatment, or they can be due to complications. So what kinds of complications do we worry about? We'll hear more about this from Dr. Hamilton, but in the course of shunt treatment, there may be complications related to the, just the natural effects of the shunt on the brain. We're taking fluid away from the brain tissue itself and to some extent from the ventricle space. The brain collapses down, and on the surface of the brain, there are small bridging veins. If those brain veins are stretched too much, they tear and bleeding occurs. That's perhaps the most dreaded complication of shunt surgery. The name for that is a hematoma, blood clot. Oops, this is what a blood clot looks like on the surface of the brain. It presses on the underlying brain tissue, and it can cause dysfunction in that area that it presses on. But the more dreaded complication is what's called mass effect, and that is that it presses so much on the brain and causes so much of an increase in pressure that the vital structures in the brain stem are compressed. This causes a condition called brain herniation, which can be fatal. In the brain stem are the parts of the brain that regulate our heart rate, our breathing, and so forth. So if those are impacted by distortions from an enlarging blood clot, it can be fatal. So this is a dire complication. It's one of the things that we worry about the most. And it's not something that's entirely predictable, but there are some things that can be done to prevent it. So what I tell my patients is as follows. First, rapid changes in head position can wreak havoc with pressures within the head. Particularly in the postoperative period, we don't want you playing basketball or doing heavy lifting. Those are things which, again, can predispose to rapid changes in intracranial pressure. One mistake that we see quite frequently is people may get a headache and they may start taking a drug like Antisiphon that has aspirin or other blood thinning products in it. And people who are on blood thinners, while they can have shunts, are at higher risk of these kinds of complications. So people who have to take blood thinners and do have shunts are advised to very carefully monitor their coagulation profiles. Dr. Hamilton is actually an expert on this, so he can tell us more about that. Finally, people who have shunts are more prone to bleeding from trauma. So if you're involved in a contact sport or something in which there is likely to be trauma to the head, you have to rethink that if you have a shunt. Likewise, if you have an accident, a car accident, or you bump your head severely in other contexts, it is something where you should consider getting an evaluation, and if the physician thinks it's necessary, a scan to rule this out. Now, subdural hematomas can occur at any point in the process. They don't necessarily occur in the first week or month after surgery. They can occur a year out, but they are more common in that perioperative period. When you contact your physician, if you experience a decline in any of the things that your shunt treats, as I said, that's not expected, with the possible exception of that first 2 or 3 week period after surgery. If you have symptoms which may be related to the shunt setting, dizziness, if you have fever, which might be indicative of a shunt infection, or if any of the sites that have been operated on appear open or not to be healing appropriately, that's cause to contact your physician. Now, the complications I've told you about have been improved by the new technology, but they have not, unfortunately, been made to go away. In the literature from the pre-programmable shunt days, we saw side effect rates of 35 to 50%. So as many as 1 in 3 to 1 in 2 patients who underwent Shunt surgery had these complications. Nowadays, particularly in expert centers, the complication rate is down to 5 to 10%. So things have gotten better, but they're still not perfect. And again, with the programmable shunts, the other benefit besides reduction of side effects is the ability to fine-tune the treatment. So one of the things we see happen sometimes after a year or 2 of treatment, sometimes there's protein or cell buildup within the shunts, and the drainage setting that was optimal for the first year isn't good anymore. And a slight adjustment can help to improve function even after 2, 3, or more years from initial placement. So finally, what are the keys to good outcomes? The first is the right patients have to be selected. The doctors who do the evaluation have to know what's real and what's not in terms of adult hydrocephalus. Assessment of surgical candidacy has to be accurate too. Perhaps most important in this process is the experience and competence and interest of the neurosurgeon. All the neurosurgeons I've dealt with in my career have been very, very competent, but they vary greatly in their experience in dealing with hydrocephalus and their interest in it. The interest is maybe not so important in the operating room, but it's very, very important what happens in the postoperative period. Working as part of a team with neurosurgeon, neurologist, and other healthcare professionals is ideal, but not every center offers that. There is also an importance to re-energizing the body and renovating those muscles and other musculoskeletal systems that have atrophied prior to the treatment. So we recommend physical therapy and an exercise program to all adults who are treated for hydrocephalus, typically a minimum of 6 to 8 weeks in the postoperative period. And as I've emphasized, I think several times now, it is incredibly important that there be consistent and regular follow-up at short intervals after the surgery and then at least once a year thereafter. Thank you. I'm going to turn the floor over to Dr. Hamilton.
Thank you, Norm. So we're going to go through a slightly different slant on this, but you'll hear some repetition because we're coming at it from different angles. So I'm a neurosurgeon, so I'm the first point of contact with patients with suspected NPH. We do all the assessment. We select the patients for surgery. We do all the postoperative care. So it's a bit of a different paradigm, but the issues are pretty, there's lots of commonality here that we'll go through. So I'm going to give you a little bit of background because I always never quite sure exactly how much depth there is or experience or exposure to the different types of things that we're going to talk about. So just that there are 3 types of common shunts. There's the VP shunt, the ventriculoperitoneal shunt, the ventriculoatrial shunt, and the lumboperitoneal shunt. And around North America, most of what you see is the ventriculoperitoneal shunt. Some VA shunts, and not as many lumboperitoneal shunts for NPH. But basically, there's no evidence that any of them are better than any other. So I think the most important thing is that your surgeon has experience and comfort level using one of these. Each of them has little issues. They all can block. They all carry a risk of infection. So it's just there's nuances, but basically your surgeon usually picks one, and in North America it's the ventriculoperitoneal shunt. Dr. Relkin showed you this diagram. I've added some moving arrows for excitement. Basically, what a shunt does, it moves fluid from your head to another body cavity. In this case, it's the belly cavity. And while that is what it does, we don't really quite understand how it affects the brain to make you better. Because when you look at the CAT scans, quite often the ventricles or fluid chambers don't change that much in size. But there is a definite effect when you see what's happened to the person who's had the shunt put in. And there are 3 parts of the shunt. So there's the catheter basically is a hollow, thin tube. So if you remember the old Bic pens where you take the insert out, about that size. There's one that goes in the head through a little hole, hooks up to a valve. The valve is there to help regulate flow. And then another tube that comes down and goes into the belly cavity. So the belly cavity is a hollow cavity with the organs in it, but it can absorb fluid. So what it does is the shunt takes the fluid from the head, ships it down to the belly, and the belly recycles it. And traditional sort of thought is that our brain makes about a half a liter a day, circulates that through the brain and the nervous system, and then reabsorbs that and recycles it on its own. So this helps deal with whatever imbalance has occurred in the brain. And I don't think we're taking a half a liter a day out with our shunts, but it just shows that there's a lot of, I think, a variation of how much fluid somebody actually needs to have removed to have a clinical effect to improve their walking or their memory. And of these 3 parts, in children, it's often thought that the ventricular catheter, the part that goes in the brain, is the one that causes the most problems. In the adult patient, it's usually, well, the valve issues we're going to talk about, it's a valve function issue in terms of trying to get it to get the right amount of fluid coming out. In terms of where it can block, it's the belly catheter. And that's quite different from most kids. And I did pediatric neurosurgery for 20 years. And as I did this transition to adult hydrocephalus care, it was quite obvious I was dealing with a whole new problem that I had not experienced very much of when I was looking after children. And as Dr. Relkin has said, basically just about everything can improve. Gait, incontinence, dementia, all somewhat depends though on how bad things were to begin with. And I think for the rapidity of improvement of symptoms, walking certainly gets better faster. Cognition can take a while, bladder can take a little while. A lot of the testing we do with the lumbar puncture, the large volume tap, or the lumbar drain, where we remove a lot of fluid over a 3-day period, the most sensitive thing, the thing that is most obvious and quickest to get better is the walking. And so that is often used as a marker of whether the shunt is working or not. And we talk about, when you have a question, is the shunt no longer working? That's one of the most sensitive things we can also look at. And with a working shunt, long-term improvement can be maintained for many people. As you're in your 80s, life becomes complicated for many reasons, and things start to layer in, and we'll talk a bit about some of those. But nevertheless, if it's the hydrocephalus, you can control that. People can have a very good quality of life and control of their hydrocephalus, as long as we keep the shunt working. So what are those other things? We'll come back to this in a bit. So other causes of dementia, so Alzheimer's. I think that NPH actually increases as we get older, and Alzheimer's disease increases as we get older. And there's lots of associated high blood pressure, heart disease, stroke issues in patients. We're seeing in North America and other places obesity, which sometimes causes problems with making the shunts work properly, but also may be associated with some other additional risk factors. Sleep apnea, diabetes goes along with the obesity issues. And then what is really becoming an issue is the number or percentage of patients who are taking blood thinners. So patients on aspirin or another platelet drug, patients who are on anticoagulants like warfarin or the newer anticoagulants that you see on TV advertised every time the news is on, the three guys out golfing, there's many of them out there. They're used for a lot of important reasons, for heart issues, for heart, people with atrial fibrillation, for stroke, and so on. But they create some issues with regards to how we manage people. If we're going to do testing or put a shunt in, you have to be off these medications for a period of time, and we have to sort out whether that's safe or not. And afterwards, going back on those medications, it has to be dealt with. And one of the questions we always ask is, if we can take them off, are we taking it off as something that, is that a choice that's a permanent choice? I mean, were they past the time where they needed it, or is it still something that's needed and there's an extra risk to having it, but the risk is outweighed by the benefits of the shunt? And so everybody has to go through that on an individual basis. So this is the thing that Dr. Relkin talked about. This is the sorting out process that occurs with, we're not going to spend any real time on that. He's talked about how you do that, where you try and select the person that fits the profile. We do the testing. We get a positive response. We talk about a shunt, and we do the shunt. So we're going to talk about is right now the follow-up after the operation and some of the issues that occur. The follow-up differs from place to place, but we see our patients, they're in the hospital for varying lengths of time, and it's somewhat determined by how bad their walking is to begin with. So some people are ready to go home in a couple of days, and some people need to go into rehabilitation for a little bit of extra care. It depends on the circumstances. They get their sutures taken out often by the family doctor in our practice. Excuse me. And then we see them usually about 1 to 2 months later. We have a CAT scan at that time, so we're looking for overdrainage issues, the subdural hematoma. And then we see them on a regular basis throughout the first year. Before they leave the hospital, I said walking is very sensitive. It changes pretty quickly. And we've done the testing and we've seen what kind of walking improvement to expect. I'd like to see that there's some evidence that that's happening. It usually happens slower with the shunt, but I'd like to see them leaving knowing that they're going down the right pathway. And if they're in hospital and we've had zero effect from putting that shunt in, and the walking is as bad as it was before we did the shunt, then we have to look at the shunt before they leave the building. We have things to do to sort that out. So the two biggies, you already heard about this, that are common with overdrainage are subdural hematoma and headache. And I'll talk a bit about headache in just a sec. What I haven't put in here is a slide about infection. Infection, Dr. Relkin mentioned, and infection is something we're always watching for. If you listen to any of the pediatric hydrocephalus talks, infection rates for children are somewhere in the 6 to 7% range. For adults, if you look at the literature, it's all over the map because people have different criteria about what's an infection and how they monitor it. It's somewhere reported between 1 and 10%, and I suspect it's somewhere between about 3 and 7% is not reasonable, but what is actually real. And there are protocols that are used that Dr. Kessel has talked about, if you've listened to talks about children and infection, where We take things that we know are likely to work to reduce infection, and we enforce them in the operating room, rigorously enforce them. And with that, we have a protocol for adults in Calgary, and our infection rate is right now less than 3.5%, so less than 3.5 in 100. Still too high in my mind. We're going to get it down lower, I hope, but infections are hard to eliminate when you're putting something in the body. It's good because you can't sterilize skin. We can only clean skin. To sterilize skin would mean that we'd have to destroy it, and that's not really practical. But so it's an issue that every center needs to be aware of, and we need to look for that. And there are infections that are quickly acting and infections that may show up 2 or 3 months later. So we need to be looking for that in the postoperative period. Overdrainage, we've already heard about the subdural hematoma. Headache is not a really big common problem with the idiopathic NPH patient, the older patient. If you start using NPH to talk about people who are in their 50s and 60s, people who probably have what I think is often a chronic congenital hydrocephalus, they are more prone, I think, to headaches with shunts. And it's something that will have to be dealt with. So we're just not going to spend a lot of time dealing with it. So this is an example of a subdural. So this is a CAT scan. It's a slice, like a slice of a loaf of bread. There's a little, you can see a part of this, the shunt. And there's a fluid collection on the surface of the brain. Now this one actually went away simply by adjusting the shunt. This didn't require any surgical treatment. And that's the advantage of programmable shunts. We have to deal surgically, and if we have time, I'll show you a quick example. We have to deal surgically with a subdural hematoma maybe about once every 2 years in our center. It still can happen when there's an unpredictable element that we don't know or understand. Something happens and the brain the ventricles just drain really rapidly, even with the safeguards we put in place. So these are the programmable valves. These are the 2 common companies in North America. There's also Aesculap as another company, but the Strata valve, and you're seeing a new Strata valve that's come out, and the Codman-Akeem valve, and there's also something called a Certus Plus that's come out. So there's different valves that are used. The beauty of these things is that you get a choice. And this is just an example of the Strata valve. So rather than putting a valve in that has one setting, that means that it's going to open when the pressure hits a certain number, you get to change depending on the circumstances. So that saves operations. It saves undertreatment. So if you put a valve in that's got too much resistance, you need to put something that's got lower. If you have too much drainage, you need to go higher. So you get to make that change in the office with the tool. No surgery required. And so I think there's also something called an Antisiphon device, which is another element in the shunt. And all of these things together that have improved shunts and have made them easier to use, safer for patients, and reduced the number of surgeries. The biggest problem in terms of numbers is shunt failure. Shunts can block. They can break. They can disconnect. It's plumbing to some degree. So we have to do everything possible to try and reduce that. The frequency is startling, actually, when you think about it. When you look at what's out there in terms of numbers, what people report. It's probably about, in the idiopathic NPH population, 15 to 30% in the first 2 years will have a catheter-related problem where the shunt stops working. And there are things that can be done to reduce that substantially, and most of those problems can be fixed. But centers need to be thinking about how to make this better. And the failure with the simplest way to remember or to think about how do you know when things are going wrong? When the old shunt symptoms come back. So lots of these things that are talked about for kids, or with vomiting, nausea, headache, they really don't have much applicability to NPH. It's basically the return of the pre-shunt symptoms. So if your walking was good, after the shunt was put in and you're starting to lose your walking ability, you should be thinking, is it the shunt? So that's the message I think that has to be taken home for your physicians, for yourselves, to understand what it is we're worried about. However, whenever that happens, look for other causes. Just because it sounds like the shunt doesn't necessarily mean it absolutely is the shunt. So patients who come in who their walking is not as bad as it was before the shunt, but their walking is not as good as it was. Is it something with the shunt? And it turns out it's a bladder infection. And they just don't have as much reserve as they used to, and it has a more dramatic effect for them. So it's a time to step back and say, what are the potential causes here? What's going on? But at least at the minimum, the ultimate endpoint should be we've made sure that the shunt is working properly. And is it one of these things that's come back into play, or has a new thing happened? So those are all, again, it's a process that you have to go through with your physician, but it is a process. There is a method to the madness. It may seem like madness at times, but there's steps you can go through. We can sort out what's going on. And it involves doing the history and physical, checking the eyes if that's necessary, neurological exam, at times a CT or an MRI scan, X-ray series of the shunt if we're concerned it's broken, and something called the nuclear medicine shunt study. And not every center uses this. I use this because it's a nice way to figure out whether there's flow in the shunt system. It's not it doesn't give you a yes or a no. It's not like two choices. Sometimes there's a gray zone in the middle. But this is where they inject a nuclear medicine tracer, and it flows down the shunt into the belly. Here's an example where they inject the tracer, and it goes nowhere. So this patient has a shunt block. Into the reservoir of the valve. The question was, where do you inject the tracer? And so each valve, or just about every valve, has a little bulb associated with it, or a place where you can tap it with a needle, and you can take fluid off, or you can inject the tracer. So this is actually a nice tool, and it helps. And sometimes we'll have patients where their shunt, we can prove that their shunt is patent, and then we'll start somebody's just adjusting the shunt down, and we know that for them we might have to go quite low in their settings to make it as effective as they need it. And we should, I think, even though it can be discouraging if somebody tells you there's this risk of shunt malfunction, if the shunt is doing what it's supposed to do and there's benefit, walking is improved, memory is improved, and if it malfunctions, you should remember that it can be usually repaired. And the vast majority of times, people will go back to the way they were. But just like Dr. Relkin mentioned with regards to the delay between diagnosis and finally getting your shunt, if you're just been to the office for your 1-year visit, and then 2 weeks later things aren't going well and your walking's deteriorating, you shouldn't wait until the next 1-year visit, because you lose a lot of ground and you expose yourself to the risk of falling. So that's in most clinics, it's, you know, if you're in and you're doing well and things change, call and we'll see you again and we'll help sort that out. Now I'm going to stop there. I have some examples of shunt malfunction if there's time. We'd like to make sure we have time, lots of time for questions. We'll stop right now, and then we'll see what Amanda has for us for questions from you. Thank you.
Thank Dr. Hamilton and Dr. Relkin for that incredible presentation. And at this time, I'd be happy to collect any questions. If you just raise your hand and give them to me, I will gather them from you. Does anybody have any questions?
Oh, I need my glasses. Wearing glasses?
So the question relates to a shunt that was placed 2 years ago, an adjustment 6 months ago. That was the last adjustment, but a year ago there was a swelling or water fluid collection around the shunt. And that was, it sounds like it's remained the same for about 6 months, hasn't gone away. So the question was, how long can this go, to completely go away? Is there any danger or concerns regarding this water? So the fluid collection around a shunt can occur because of bypass around the catheter. So the pressure inside is not very high, so that to get out of through the shunt, which is where you want it to go all the time, requires that the pressure reach that sort of threshold that the valve is set at, where the valve is adjusted to. So anything lower than that, or if it doesn't sort of reach that point, it can sort of leak out around the valve. It usually doesn't do any harm. It doesn't, as long as the skin isn't under tension, as long as there's no evidence of infection, it usually doesn't produce any long-term harm. They usually don't develop later. They're often things that develop early on when the shunt's put in, if they're going to develop. They're not terribly common in adults, but they're pretty benign most of the time.
Were you, just out of, I was going to, so there are, as we mentioned, subdural hematomas. There's also something called subdural hygromas, which are inside the head. Are you talking about something that was seen on a scan inside the head, or something literally around the shunt bulb?
That's correct. It's around the whole front. It's not around the actual.
Oh, so on the
It's a hygroma in the front of the head.
Oh, okay. So
Okay.
on the inside, right? The outside, okay. So those can, as long as they're not causing a problem, we will watch a lot of those without, and they will stay there forever. It depends on the size of them.
Surgeons said it came from the adjustment.
Right.
Yep.
From overdrainage.
It's not necessarily overdrainage.
Off and went the other way.
Yep.
Right. So hygromas are, they're not literally pathologic, and in fact, there's some evidence that space that opens up on the top of the brain may be part of the way that the shunt has its benefit. There's some evidence that individuals who have normal pressure hydrocephalus have a kind of blockage of the circulation of the spinal fluid over the top of the brain. And when we produce spinal fluid in the center of the brain, it circulates down through our spine, back up to the top of the head where a vein helps to clear it. In the course of the ventricles enlarging, that vein gets compressed against the skull. And one of the benefits of a shunt may be that the brain collapses down a little bit and allows that fluid to better reach that central vein. Now, that being said, the real limiting factor of a hygroma is that the surgeons will be more reluctant to do future adjustments with the hygroma present. Depending upon how large it is, some surgeons will do what Dr. Hamilton described is often done for a hematoma, which is they will turn up the setting for a period of time to see if they can get resolution of the hygroma, and then gradually reduce it in an effort to get best symptomatic response. But other than that, it's a pretty benign thing to have.
Yep.
Yeah. We can.
So I have low pressure hydrocephalus, and I have a shunt and an ETV. Can you address what the failure rates are or the success rates are of those conditions?
So low pressure hydrocephalus is a very different phenomenon from normal pressure hydrocephalus, and probably if you have specific questions, we can. I'm happy to talk to you later because it's going to take us down a very different road. But the shunt itself, the failure risks of the shunt, the issues of blockage of the catheter, infection, overdrainage is usually not a big issue, but underdrainage are all the same risks for low pressure hydrocephalus. But it is quite a different entity.
But as a generic statement, what do you think the failure rate is for ETV?
So as a generic answer,
yeah.
You need to define what the parameters are of who you're doing the ETV on. So we just published a series, or it's in press, looking at ETV in adult patients, and again, it's properly selected. If it provides the benefit that you want, which happens in about 85 to 90% of people, the failure rate is extremely small.
Very small. So those of you not familiar, ETV stands for endoscopic third ventriculostomy. And it is a procedure that has the advantage, it's done with an endoscope, so a minimally invasive device, and it introduces a conduit or a passage between two different compartments inside the skull. So instead of channeling the fluid to another part of the body like the shunt does, the ETV simply redistributes it within the skull so better circulation can occur. Now, ETV comes up quite frequently in these types of discussions, but it's not an accepted treatment for normal pressure hydrocephalus in older adults. It was tried as a treatment. It would be wonderful to not have to put a plastic device into the head, but ETV doesn't work that well in the context of run-in-the-mill idiopathic normal pressure hydrocephalus. In younger patients and in patients with other forms of hydrocephalus, obstructive hydrocephalus, aqueductal stenosis, ETV is perhaps the procedure of choice.
So we are actually at time. The wonderful thing is that Dr. Relkin and Dr. Hamilton will be outside and around for the rest of the conference. But I want to thank you all for coming. I want to thank you for joining us at home as well. And I would definitely love to thank our two experts in normal pressure hydrocephalus for joining us today. So if we can give them a round of applause.
Thank you.